everybody. Welcome to OsteoBites. Thanks so much for sharing your Thursday with us. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Kevin Campbell from Children's Mercy, Kansas City. Dr. Campbell will discuss the phase 1 study of Cabozantinib in combination Topotecan-Cyclophosphamide for patients with relapsed or refractory Ewing sarcoma or osteosarcoma. Thank you so much, Dr. Campbell, for joining us today. We are thrilled to have you. And thank you also to our panelist Walker for joining us today. A little bit more about our guest today before we get started. Dr. Kevin Campbell is a pediatric oncologist at Children's Mercy, Kansas City, and a clinical assistant professor of pediatrics at the University of Missouri, Kansas City School of Medicine. He has an interest in clinical trials relevant to children with solid tumors, with an emphasis on neuroblastoma and sarcomas. And during his training at Dana-Farber Cancer Institute, Boston Children's Hospital, and now extending into his career as an attending, his research focuses on clinical outcomes for patients with high risk or advanced solid tumors and the development and implementation of early phase clinical trials with novel agents or combinations of agents to improve outcomes. His work to advance clinical trials includes experience in multiple spheres. He has completed specific training in the writing, development, and management of early phase clinical trials, and currently has a phase 1 clinical trial open, which he developed. His work also involves the analysis of biomarkers that have been incorporated into national phase 2 and phase 3 clinical trials. So thank you so much, Dr. Campbell. Really excited to hear your talk today. Just a couple of announcements before we get started. Our next virtual tumor review board for osteosarcoma, which we affectionately call Turbo, is on May 8th at 5 Eastern. And if you are a clinician interested in attending or presenting a case, you can email me at christina@mibagents.org. I'll also put some more info in the chat about that. But we also welcome researchers to this educational forum, since it's a really great opportunity to learn about real-world clinical challenges. And we are just, gosh, what are we, 2 months away from our Factor Conference, which is June 20th to 22nd in Cleveland this year. Spots are going quickly. Our registration is actually filling up really quickly this year. So be sure to save a spot, register now. Factor is really unique in that it brings together everyone in our osteosarcoma community: clinicians, researchers, patients, caregivers, patient advocates, funders, and industry. And if you're listening to this webinar, then you belong there. We have some great panels this year. We have, I think, like 10 scientific panels. Some of the topics include overcoming drug resistance, key pathways in osteosarcoma treatment. We also will have our clinical trials panel again this year. We have a great panel on preclinical models. And we have our very popular patient panel back this year, which Walker will be on again. And then we also, for our families, have some great wellness classes. We have yoga, the very popular sound bath. We have an osteo warrior this year, and vice president of our junior advisory board, Max Penzer, is going to be teaching a crochet class. So lots of great things happening at Factor this year. I'll put some more information in the chat about where you can find the agenda and how you can register. And there is going to be a prom after Friday dinner this year, which is a new thing that we're throwing in the mix. So I know Walker's going to be there. So that's kind of reason enough to come to Factor and hang out at the prom. If you missed it your first time around, or it just didn't meet your expectations the first time around, this is your chance to have your, the best prom ever. All right, Walker, can you go ahead and introduce yourself?
Yeah, hi, I'm a Osteo Warrior. My name's Walker. I'm part of the series MIB Junior Advisory Board. I said the same thing last week. Factor's the best. You got to go for sure. I'm very interested to see what prom has to hold. Don't know too much about that yet. But overall, I got to see today's slides beforehand, and I'm really excited to hear more of what Dr. Campbell has to say. So you can take it from there, Dr. Campbell.
Great, will do. Thank you, both of you, for the introductions, and Christina, thank you for giving the background of kind of where I've been and what I've been doing. I'll elaborate on that a little bit as I go through, because I would hope that anyone that has any questions or interests related to anything that I've done, or might have the ability to answer a question that is unrelated to this topic that I'm going to present about today, but might be related to my interest in general, I'd be happy to answer those. So please feel free to do so. So today's presentation, as we alluded to, is going to be about a phase 1 trial that I developed and ran and have completed, and results were published last year. This was all done while I was working at Dana-Farber, but as we alluded to, I now am at Kansas City at Children's Mercy. So I was born and raised in Kansas City, and just was in Boston for about a decade for my medical training and early career before returning home to raise some kids and work here at Children's Mercy in Kansas City. Part of that also is that I'm going to talk about kind of the nuts and bolts of how this trial was made and done. And part of my goal as an oncologist is to be able to develop further early phase, and when I say early phase 1 and phase 2 trials, or just open ones that are open at other institutions, but have them open here locally in Kansas City. Although it was wonderful to have patients come from far away to have their treatment at Dana-Farber in Boston when I was there, it was also eye-opening that that's really difficult on patients and families to have to travel somewhere when they're not feeling great, when they're sick. And part of my goal in Kansas City is to eliminate the need for travel for some patients that are going to be closer to the Midwest, and allow them to get the treatment that they want that maybe is not yet available here, but make it available for them. So that said, the first couple of slides will kind of be just about how I developed the idea for this trial, and kind of maybe a little bit on how that's done before we get into the actual nuts and bolts of the trial and the results. And this, might just pertain to anyone interested in, how we come up with a phase 1 trial or not. But in general, phase 1 is the first time we've tested in patients. A phase 1 trial in kids doesn't mean that it's the first time a person has ever had it. A lot of phase 1 trials have to do with medications that were previously used in adults, or actually previously used in kids too, but just it's a novel combination, which is the novelness of my phase 1 trial here, is that Cabozantinib, I'll show you, had a lot of results already with patients. So did Topotecan-Cyclophosphamide, but the uniqueness of this trial and why it's a phase 1 trial was that they'd never been combined before. So we always like to start off with low numbers, make sure that what we're doing has the ability to help in a way that we would want to treat more patients than if we get good results. So the rationale behind this I'll go into a little bit more, but as just a general overview, Cabozantinib is in a class of medications we call a TKI, or a tyrosine kinase inhibitor. There's a number of those, which I'm sure some of you are familiar with. It acts a little bit differently, which I'll show, which is maybe why we were excited to pick it. Overall, this process, it does take a while. Phase 1 trials are much quicker than a phase 3 trial, which take a decade or so to come together and enroll and treat and get results. Phase 1 trial is usually a 1 or 2 or 3 year process. As you can see here, it kind of took me a while to get it all finished from the beginning to publication time. And I think that's just a little overview of kind of, timelines, how that would work. So to address, why we decided to pick Cabozantinib plus Topotecan and cyclophosphamide, really the exciting part for us was, I'm gonna maybe skip ahead a slide. Yeah. So there was a study called Cabone, which was a European study that looked at single agent Cabozantinib, so just Cabozantinib, in patients with relapsed osteo or relapsed Ewing, so our population too. And they saw some nice results, which I'll show. But them being able to do that was also in concert with the Cabozantinib already being studied extensively in our pediatric population through phase 1 and phase 2 trials, where it was the lone medication used for these groups of patients. So just some stats there on kind of what the phase 1 and phase 2 trials of single agent Cabozantinib resulted in for our children's oncology group phase 1 and phase 2 trials. And the note up top that Cabozantinib has actually been used pretty extensively in adults. So it's used frequently in renal cell tumors, which is what the Comet and Meteor trials were, but they have a lot more data about kind of side effects profiles and dosing and stuff in the adult land. So this was a publication in 2020 from the Cabone study. Again, this is relapsed Ewing's, relapsed osteo. You're seeing the Ewing's there on the top and the osteo there on the bottom. And what we're looking at is called a waterfall plot, just because it kind of looks a little bit waterfall-ish. We don't really like the red color. That means the tumor grew or got bigger from baseline. we like the downward direction. That means that things improved in terms of size. And then the color denotes how much of a change things happened. Did it reach a point where it was what we call a partial response, or was the change not as significant? We just would label that stable disease. So those terms are very quantified. So even though something might decrease 20-25% of its size, we would still label it as a stable disease and not a response. So just a little bit more background in terms of how we denote some of these changes. But in general, what we're seeing here is really promising and really helpful and exciting to clinicians and patients and families, that just using cabozantinib by itself can work for a number of patients to not only control disease, but actually make it smaller. And so we're seeing a lot of downward direction here. Obviously, any upward direction is not good, and we don't want it. But in terms of comparing this to past results, this was pretty good. So I think the population of providers that deal with these tough diseases in the relapse setting, we're excited to see that cabozantinib had some real effect here. The thought maybe is, so on the bottom here, we're seeing 8 different names for different tyrosine kinase inhibitors, and there's a few more on top. The idea here is just that there's a lot of what we call TKIs, and why is cabozantinib maybe a little different, or why is it working better than the other ones? And as you can see in this diagram, there's action or inhibition, I would say, at the c-Met terminal, which is something that has to do, it has downstream effects with vascularization. So there's a thought process that part of the difficulty in delivering our kind of historical chemotherapies, so like the IV chemotherapies, Topotecan-Cyclophosphamide in this sense, when you give that to the body, usually your blood vessels, it goes through your blood, it goes through your blood vessels, and it reaches everywhere, basically. We have side effects everywhere in the body, but we're really obviously just wanting it to kill the cancer cells. Well, there's some discussion and some concern that because cancer is just such a disorganized growth, and that it's not growing in a normal fashion, it also doesn't have blood supply in a normal fashion. And so that it's possible that at times we're not delivering the chemotherapy to all the parts of the tumor, even though we're giving the chemotherapy intravenously. So being able to control how the tumor makes its blood vessels, and to maybe have the tumor make its blood vessels in a more normal fashion, would be advantageous to us, as it would allow us to kind of deliver that other chemotherapy in a more practical way to get to all the tumor cells. So that was kind of just an overview of maybe why the action of cabozantinib might work differently or better in this scenario, and why we would think also then to combine it with other chemotherapy, is that they could kind of have a synergistic effect in that sense. Sorry, yeah.
Oh, Dr. Campbell, can I do a quick rewind back to your waterfall plot?
Please. Yep.
Question. So the red bar that's in all the green, amidst the green bars on the osteo.
Yeah.
Can you explain that one?
Yeah, that's an odd one. So that does mean that the patient's tumor got, what we say, over 30% smaller. But it's likely, I'd have to read exactly, but it's likely that they found a new tumor in another place. So anytime if there is a new spot where there wasn't before, no matter what the biggest spots change, we would label that as a progressive disease. So my intuition is that patient, although they had significant control and decrease of size of over 30% of their primary location, they experienced a new spot somewhere else, and that made them get labeled as progressive.
Got it. Thank you.
Sure. So then, the phase 1 studies or the single agent studies of cabozantinib had been done, and our job was to say, how can we improve upon this? How can we give even better results to our patients? And as we said, we wanted to pick some chemotherapy that's got some proven results with these two diseases that would maybe not overlap with the side effects of cabozantinib. And there are really 4 candidates. There's a lot of different ways to treat relapsed osteo and relapsed Ewings, but in terms of the most common and most practical chemotherapy backbones, these 4 were kind of, I'm showing this study because it elaborates on maybe that we didn't know, and maybe we still don't know exactly, but there's kind of 4 commonly used backbones for relapsed Ewing sarcoma. And there was a study done in Europe called RECUR, where they just studied and they said, okay, relapse Ewings, we're going to try these 4 and see which one works the best. And at the time that we were making our decision, they had already ruled out the bottom 2 as not working as well. So we felt that we had some definitive data that said one of these 2 backbones is probably our best bet. And then we thought about what the overlapping side effects of cabozantinib, which includes some renal side effects, would have. And we found that topotecan-cyclophosphamide would likely prove least concerning in terms of a safety issue for us. So that's how we picked topotecan-cyclophosphamide. And like I said, this is me and my phase 1 team, and we're just meeting and going over data and poring over things and, just trying to find the best idea that we can. A lot of times phase 1 trials are done in conjunction with a brand new agent, not a combination that I'm doing, but a brand new agent where you're working with outside institutions that are making their own drug compounds, like a pharmaceutical company, et cetera. That was not the case in this. This was us just identifying that we had improved in good data with cabozantinib and wanted to improve upon that. So a phase 1 trial is pretty standard in what you're trying to achieve. You're basically just trying to prove that something is going to be safe and tolerable, and then recommend a dose that is safe and tolerable, so that if you do have good results, you can move on to a phase 2 study. But when you set up that phase 1 study, you're really designing it to make sure that you are keeping safety first in as the goal for the patient. And obviously we're all hoping for improvements in outcomes, but we designed the study to first make sure that what we're doing is safe for the patient. So that was just the definitions of our primary and secondary objectives there. What kind of took a long time is just sorting through the logistics of what issues we might run across in terms of dosing that would be reasonable, dosing that would be safe, how to make sure we could get the cabozantinib, what medications people could be on if they were on these medications. And so as you can see here, we had to make some exclusion criteria that was not too hindering for us. There's not a whole lot of patients that have relapsed Ewing's or osteo that are less than 6. And the BSA criteria was pretty open. There was a few patients that were kind of on the cusp of those, but overall, I felt that was not too much of a hindrance to us. And the reason we had to do that again was just the cabozantinib only comes in so many dose forms, as you can see there in the pill bottles. And to be able to dose it correctly, we had to have patients within a certain weight class. We didn't want our patients to have had use of previous cabozantinib, but given the fact that topotecan and cyclophosphamide are very common, we were okay if they had that before. As again, we were just kind of testing the novelness of that plus cabozantinib. Cabozantinib, like a lot of other TKIs, it hinders your ability to heal wounds and heal cuts, and that kind of goes along with what I was talking about earlier about its action about how it interplays with the cancer's own ability to make vasculature, and then obviously the normal body's it has an effect on that too. Blood pressure is an issue with TKIs, and then there's a certain medications that don't react well that we were excluding. So this is an overview of what the trial looked like. It's always nice if you can give the trial some quick nickname that everyone knows in terms of referring. So I called it Cytoka after the first 2 letters of all of our agents. So that's, when we would talk about it as a group or with patients, Cytoka was a lot easier to say than the whole, 20 long words. So I'll refer to it as that going forward. So the patients received the standard chemotherapy agents, cyclophosphamide and topotecan, for the first 5 days of a 3-week cycle, and then the cabozantinib was given every day of the cycle, of a 21-day cycle. So you're taking cabozantinib continuously in that sense. We started off on dose level 1, which the recommended single agent dose of cabozantinib from what I referenced before, the COG trials and also the K-bone studies, was at 40 milligrams per meter squared per day. But given that it was the more experimental of the 3 medications, we felt that it was best to use the standard dose of topotecan and cyclophosphamide and actually reduce the dose as we started with cabozantinib to make sure that was safe before we escalated to possibly using full dose cabozantinib with full dose cytotoxic chemotherapy. And then I'll touch on dose levels 1A and 1B, or negative 1A and negative 1B shortly here. I'll also touch on this after we discuss the results, but there had been evidence that starting all three medications at the exact same time might be a little hard for the body to adjust to immediately. There had been prior studies and ongoing studies about giving a TKI, like Cabozantinib, with cytotoxic chemotherapy, and that possibly a kind of a ramping up of dose could be helpful, where you give the patient kind of a week off or a lesser dose of what you're going to give them in terms of the Cabozantinib, and then go to the normal dose starting on day 8. So after all the IV chemotherapy has been done. So for cycle 1 only, so the first time that someone would see these three medications, we decided that we were going to do that, have a lower dose for our startup dose of level of 1. And then, as you can see, if someone was on a different dose level, that would also be different. So this is for cycle 1 only. We got what we call a ramp up. We enrolled 12 patients. I'll show you kind of the schematic of how they enrolled and what happened with them, but it was a 3+3 trial, meaning we enrolled three patients at a time. We got a total of 12. As you can see here, we had 7 with a diagnosis of relapsed or recurrent Ewing's, while 5 with osteosarcoma. The patients were majority male, and we had a range of race. At enrollment, patients were teenagers. We had a patient that was 33 years old with Ewing sarcoma that enrolled, but other than that, they were all teenagers, including all the osteosarcoma patients in between ages 13 and 17, as you can see there. The amount of time that it took patients from their initial diagnosis, so when they first heard that they had osteosarcoma or Ewing sarcoma, to the time where they came to us, was just over a year, actually a little bit less for osteosarcoma. And the number of prior therapies that they had been on was a little bit more for Ewing sarcoma than osteosarcoma. You can see the osteosarcoma population, 2 of them had just come off of upfront therapy, while 3 of them had had at least one more systemic therapy regimen.
Wow, I'm blown away by the 10 number.
Oh yes,
That is one patient
yeah,
who- and-
yeah, we
right.
had to double check that one,
Yeah.
the patient was like, they were telling the truth, and
Wow.
they had the medical records to back it up. So yeah. So this is a 3+3 design. So this design, the only thing that is not true for every 3+3 design is that date at the top. That's just the date that I started the trial. But if you're hearing about a 3+3 trial, this is how it would be set up for anything. So you would enter 3 patients and you treat them at a certain dose level. Again, usually dose level 1 is your starting dose. And if after those 3 patients, just going over to the far left, you don't have any what we call DLTs or dose limiting toxicities, then you could move up to the next dose. If you have just 1 out of 3, then you enroll 3 more and see what happens as we look at the center of that. And then to the far right, if 2 out of those first 3 patients don't do well and have DLTs, then you have to move down. A DLT or dose limiting toxicity is very specifically defined before you open a trial. So it's not something that we just, a patient's not doing well and we say, oh, let's label that as a toxicity, or we think that's okay, or we don't think that's okay. These things are very, very prescribed, documented out, that you kind of, as the doctor, you might have wish you would have thought of something differently, but basically when you start that trial, everything is set in stone. And even if there's a thought process that a toxicity, someone falls and breaks their arm and they fell because they were pushed by their brother and they broke their arm because they fell from it was a big fall and they hit the rocks or something. If they're on the trial and they're getting treatment while that happened, we have to assume that there could have been some way that could have been related. Maybe their bones were a little brittle or this or that. But just a little tangent on what a DLT is and how kind of anything that happens to a patient when they're on a trial, you do not assume that it happened any other reason besides them being on the trial. So after 3 patients, we had 1 patient that experienced a dose-limiting toxicity. So we stayed with our dose level 1. Unfortunately, we had 2 of the next, so more than 2 patients out of the 6 that we first enrolled did have a dose-limiting toxicity. So that brought us to either proceed with dose level -1A or -level 1B. And as I showed earlier, so those are 2 different things. And that was again, very prescribed out situation where we had to say what DLTs were and what they were likely related to. So we had said, these are all the DLTs, and if these ones happen, we think that's going to be related to the cabozantinib, and if these ones happen, we think it's more likely they're going to be related to topotecan-cyclophosphamide. We found that our DLTs were more likely to be related to the cabozantinib. So -1B is where we kept the same dose for topotecan-cyclophosphamide and reduced the dose for the cabozantinib. Whereas if we would have thought the other way, then patients would have gotten one less day of the IV chemotherapy and continued on the same cabo dose. So that was our end dose. Again, we had 12 patients. They're all represented by a different bar here. And this is how long they were able to stay on treatment. So again, a cycle for our therapy or our trial was 21 days. So the duration of treatment there on the bottom is measured in months, which is not exactly equivalent to cycles, but is semi-equivalent to cycles. So you can see that there were a number of patients that were not able to stay on for that long, but we did have 5 that were on for a pretty long time, including one patient that was on for over half a year. So,
Dr. Campbell, was that duration a factor more of the dose-limiting toxicities or just progressive disease?
Actually, I'm glad that you asked. I meant to add an extra comment here. Out of the 7 patients that stayed for less than 2 months, 2 of those patients had reason to come off for dose-limiting toxicities. 5 of those patients actually came off because they lived really, really far away. They came to Boston to enroll in the trial and start in the trial, and you're not allowed to be on the trial if you are being treated somewhere else. So in 5 out of those 7 patients that were on for a short amount of time, it actually was the case that we just got in contact with their providers from where they were from, and we told them exactly what we were doing, and they went home and got the same treatment, but just what we call off trial. And so when they go off trial, we're not allowed to say that they are being, still on the trial, and therefore their duration of treatment theoretically stops. But in real life, these patients went on to actually be on the same treatment for quite a longer period of time. So that actually makes this chart this chart is a little bit false in that sense, where it shows a lot of patients only being on for a short amount of time, but these were actually almost agreed upon beforehand scenarios that we told patients, yes, that you can come here and we'll start you on treatment, and if you're doing well and you want to go treat at home, then we'll do that. And that's, again, what I touched on earlier, a significant kind of goal for me is to not even have to have those patients do the traveling at all, but for them to say, hey, there's this trial in Boston that looks like it's a really good idea for me, and hopefully they won't have to tell me that. I can tell them that, but then I can also say it, and we can just do it here. So traveling when you are very sick and being away from your all of your family or your friends, and missing out on important things in life. These patients are 13, 14, 15, 16, 17 years old. It was painful for me as a provider to know that I was mandating them having to come to Boston when they had other things they wanted to be at, and is a source of pride for me in the future if I can alleviate that travel that's really a burden on a lot of the patients when it comes to kind of where they are in their lives and their disease to have to travel. So these are just the readout of the grade 3 or higher grade AEs or adverse events. So there's a very standard way to grade or assign a level to an adverse event, which is what the AE stands for. And something that is a grade 1 or grade 2 is generally very mild, and you don't really have to intervene so much. A grade 3 is where you really have to start intervening. A grade 4 is incredibly serious, and a grade 5 would be a death. So that's how to think about these in terms of severity. So I listed out all the grade 3 or grade 4 events that happened. We certainly expected a lot of decreases in our platelet counts, neutrophil counts, et cetera. So those are not really a surprise or a problem. The bottom half of these adverse events is really more attributable to the cabozantinib. We don't see the bottom ones generally as much with our cytotoxic agents. And we didn't have anything terribly unexpected or out of scope. Again, we did have actually someone that had a fracture that was caused, probably not by the drugs, but we couldn't say for sure. But that was the report that we have. In terms of response, we saw kind of some of the changes to, I'll show a waterfall plot that we've already seen a waterfall plot, but not of these results. But we had one patient with Ewing sarcoma that had partial response, so more than 30% decrease. We had a number of patients that had stable disease. And then we had a few patients, especially in the osteosarcoma group here, as you said, they're listed as unknown. And that's because you had to be on the trial for a full 2 cycles and get your CT or your MRI done at Boston after cycle 2 for us to be able to report it as known. So these 2 patients were patients that were doing well on the trial and just decided to continue to get home treatment at home, but we're not able to report that they were able to their scans, given that they did not occur at our institution. So this is another waterfall plot, a little more simple than the one I showed earlier about the K-bone, but this one shows for the 5 patients that had measurable disease. So there's a number of patients, if their disease involves the bone, because we don't expect the bone to decrease in size, we can't really measure it. So for the patients that had measurable disease that was not involved with their bone, we saw 2 of those tumor sizes increase after therapy and 3 decrease, again, with one of them being able to be labeled with partial response as it was more than 30%. One of the nice things we were able to do is also a collection of ctDNA or circulating tumor DNA. So there's growing evidence that although these are solid tumors, they do kind of shed some of their tumor into the blood system, and it's circulating, and we might be able to measure it. So that's something that is being kind of spearheaded, and a lot of work being done in Boston, and I'll try to continue to be a part of that. But we were able to measure circulating tumor DNA before treatment and kind of within that first cycle a few times, as well as later in treatment. This top one here is our osteosarcoma, and the bottom ones are Ewing sarcoma. So the osteosarcoma, we can see that the amount of tumor DNA that's circulating is actually very much being able to be quantified. Like we observed it, and we were able to find that circulating tumor DNA in all 5 of the patients at the starts of treatment. And in most cases, we found that the levels go down as you give treatment, which is what you hope. This obviously, it's not like a exact replica of what you would expect for size of tumor, because even kind of dead tumor is circulating tumor DNA. So it's unclear on kind of how fast you should expect things to drop, and when it should clear. Obviously, we would love to be able to know those answers and working towards those answers. And I think circulating tumor DNA is only going to get to be a louder and more known idea when it comes to treating osteosarcoma as well as Ewing's. So at the end of the study, we were able to say our dose level -1B, which was not starting Cabozantinib until week 2, along with the historical dose of topo and Cy, was our recommended dose for a possible phase 2 treatment. And that when you combine these agents and you give the Cabo on the same days as the IV medications, you have more common side effects. And in terms of patients that had a measurable response, it was only 1 of 12. This slide is just, it's a lot of words, but it's just also here to give some evidence that what we found, it was not actually the only time this has been found. There's been other studies that have combined different TKIs with different chemotherapy backbones that have found kind of the same idea, that when you give both of these medications at the same time, you're apt to have more side effects. So if I were designing this trial again with all the evidence that I had, I think that starting Cabozantinib after I was done with the IV medications would be the way to go. And I think that would be, there's data now to kind of support that idea of what we call not using concomitant or not dosing these things at the same time. So giving them at different times. And then lastly, just as this talk centered on Cabozantinib a lot, I found it interesting that this was published recently. This is a Canadian study that just basically said, hey, let's look at all of our patients that have relapsed bone tumors over a 5-year period, and if they got these 2 drugs, either Cabozantinib or regorafenib, and just see how they did. So I just thought this might be interesting to present as I was presenting my study. And they found that there was a good amount of patients that had received Cabo 37, only 14 with osteosarcoma, and they reported their starting doses and toxicities. And I found it to be kind of similar in line to my experience. So there's a growing body of literature to understand what Cabozantinib does and doesn't do, and what side effects to expect and not expect. And that leads me kind of to my last point, which is that I'm sure people might know this, but cabozantinib is being studied more extensively now in the osteosarcoma population. There's a phase 2/3 study. So that means it's a study designed to have a phase 2 portion that then immediately after it's over, if it goes as planned, a phase 3 portion would open. So kind of planning both of those at the same time so that they can get them done quicker. And they're going to use cabozantinib on top of the backbone of MAP chemotherapy that is well known to our osteo population. So that's exciting that Cabo is going to be, continue to be studied in this way, and more upfront will be good as well.
You
So
know, in that study, is it non-concomitant in that? Is it?
they're experimenting that right now. So that's a great question. So on the bottom, you can answer that's being looked at is what should it be? So actually, as a lead into the phase 2 study, there's a feasibility or dose finding phase as like the entrance to the phase 2, which they're actually they've just finished that and they're kind of awaiting results before they decide on how they want their phase 2 to look. But that's exactly what they're trying to understand before they open it up to a larger audience is should they give it at the same time and what's the dose level? So that's what this slide alludes to is just that they're going to have a lead-in dose finding phase before they open that phase 2 portion. So that's the extent of the presentation. I want to thank the team that worked on Cytoka with me as well as some funding, but moreover, I was, very excited to be able to present to your group today as patients and families are, I think, the number 1, 2, and 3 people that we need to thank for these studies being able to go forward. It's as I've seen with my young career, it's very difficult and a very difficult time, very difficult to travel, very difficult scenarios in general for patients that have disease in this form. And it's always awe-inspiring me that they're looking to help the community at large and not just themselves when they enroll in these studies. And so I would be remiss to not really point that home when I'm presenting to people that probably know that firsthand and have maybe known people or are themselves a part of this community that has allowed us to study not just them, but the results in general when we treat them. So thank you very much to anyone who falls into that category.
Thank you so much, Dr. Campbell. And everyone, please feel free if you have a question to pop it into the Q&A. And I think, Walker, you might have a question that we can kick it off with.
Yeah. I guess I have a question specifically about cabozantinib, and then with it being TKI, I guess my question is, I assume there's more tyrosine kinases throughout the body than just ones that are promoting like cancer growth. And so when you use the TKI and inhibit all those, what are the side effects that come from that, or if there are any?
Yeah, there are for sure. So I'll just not make people too dizzy, but scroll a little bit as I answer those questions. So there's a lot of the main things that TKIs do are inhibit these VEGF receptors that you're seeing here in the middle. So it's showing that all 8 of those different TKIs in the bottom are going to hit those 3 VEGF receptors. And then there's a lot of other targets that some of them just hit kind of one-on-one. And so what does this mean for the rest of the body and not just the cancer cell is a great question. And does take some in phase 1 trials to really understand what happens in a human. We obviously study these before we give them to people in labs with mice and other mammals, but are not able to get a true really understanding until we're using it with humans and with other combinations. But as we kind of set up and expected from studies that had shown cabozantinib just as a single agent, we knew that blood pressure, for instance, was a issue. So there's a renal effect or a renal injury that happens with use of cabozantinib, and we knew we were going to have to watch out for that. We knew that although we're happy about it kind of going and messing up the cancer's ability to make blood vessels, it also impairs the normal wound healing. So that's an issue that we were having to always watch with. And then it's filtered by the liver, and there's different medications that are also filtered by the liver in a similar way that we knew that if they were given together. So at the very bottom there, we have a list of things that we couldn't allow to be given at the same time as the cabozantinibs. We knew we just wouldn't be able to. And so those are a few of the side effects. And then I'll just point out that our side effect profile seen here Towards the bottom where we have the bottom half of this, I would say that we did not expect typhlitis, a fracture, syncope, suicidal ideation. We did expect hematuria. Again, that's kind of a process of renal injury. Epistaxis was expected, maybe not again to the degree of third degree, but epistaxis is a bleeding issue, or people that are just prone to bloody noses are going to have worse bloody noses when they're on cabozantinib because we're messing their body's way to kind of heal vasculature. And then hypertension is also expected. That's a function of renal injury. Pneumothorax and weight gain were not, and hypoxia were not really expected. So good
Okay.
question.
So how do you, since this is like a multi-drug
Mhm.
treatment, how do you differentiate between what drug is causing what? Because like I know for me, when I was
Yeah.
getting treated,
Um,
I had a lot of those same side effects, but I wasn't taking Cabo or
Yeah,
Campbell.
the answer is you do it beforehand and you just use the data that you have. But you do it beforehand in the sense that as a provider, you're going to want what's best for the patient, and the patient's going to want what's best for them, and there's going to be a lot of emotion with a decision about attributing something to something. And if you put yourself in a position to make a decision when you're in real time and you have that emotion, you're not going to get the overall truest results. So you pour over the data, and before someone enters a trial, you label each thing as, I think this is more likely to cause this and this and this. And once I do that, I did it with my team, and we had all the data there, and then I submit it to a panel of experts in the hospital who also review it and agree with it, so that I'm not just having that by myself. So it's a peer reviewed process where we say, we're thinking that these side effects might happen, and if these happen, this is how we're going to attribute them, because exactly as you said, they're taking both medications, so we can't be 100% sure, but in a way to try to make it as fair and non judgmental down the road, we do that beforehand.
Gotcha. Thank you. Um, there's a question that just came in the chat, and they ask, did you assess overall response to pain, specifically musculoskeletal pain, before and after drug treatment in these patients?
Yeah, that's a great question. So I don't have all of the requirements for having to be eligible for the trial here, but one of the eligibilities that we did have was that you didn't have significant pain. So we used accepted pain scales and accepted functional scales. So you had to be functional to a degree where you were up walking around doing daily activities to a certain degree. So both pain and activities were important to make sure that patients were able to kind of move around, do what they need to do, but also if they did have pain, that we were treating it in a way where it was well controlled. And as you can see, or I don't know if it's on the bottom there, there were a few different types of pain medications that were prohibited. So we would have to, at times when patients came to us, say, we're going to switch your pain regimen, which was a little scary for some patients that had been on a stable pain regimen for a while, but we couldn't have their medication present during our study. But absolutely, if there was a change in their function or a change in their pain, those are possible side effects that have grades just like these, or just like these ones do. So I just listed here the grade 3 or 4 effects that we had, but there is a very, very long book that's over 100 pages that has way more things that are possible to have, including all different types of pain. So if that would have been something we would have seen, we would have reported it and possibly had to change somebody's dose if their pain was out of proportion.
Sure. If there's any other questions, nothing from the chat right now.
I had a question, Dr. Campbell, about just whether or not, I know you talked about doing some ctDNA analysis, but wondering if you've been able to do any other correlative studies to determine biomarkers of response. So just if there's anything that correlates for the patients where you did see stable disease or partial response, whether that's like tumor size even, or just genomic sequencing, or even what they were pre-treated with.
That's a great question. Yeah, so we did look at as you mentioned, I don't know where that chart is, where we have but yeah, you saw that we had a few patients that were on 1 or 2 or 10 regimens before. We looked in to see if there was any connection with that. We were not able to draw any conclusions just with our low numbers, but that was a thought. It was also a thought that how close they were in terms of time span to the last round of cytotoxic chemotherapy they had gotten. We had a washout time period of a few weeks where they couldn't have had anything before, but I was interested to see if there was any relevance to how much cytotoxic chemotherapy they had gotten before and their bone marrow's ability to respond or kind of get their numbers back up. Because it was a problem if we had to delay therapy because their red cells or their white cells or their platelets were not high enough. We didn't find a correlation there either. My intuition says that younger patients and patients that had less chemotherapy overall tend to have a more robust response to therapy and get their counts up more. In terms of the question before that about other markers that we might be able to have correlative data for, we certainly looked at all the genomic issues that arose with each individual's cancer and thought about if there was any better way for. So the answer is not really with that. There are thoughts that certain genomic lesions or certain genomic issues that we see in osteosarcoma might respond in different ways to different treatments. And we certainly weighed in if we thought that were the case and telling patients, actually, this trial that's open over at this institution actually might be better for you. That happened once. But in general, we love having all the data we can. At this point, we're not to a point where we can say that we know exactly what we're doing with all of it. We're still learning from it. And ctDNA is, I think, a little bit more out front in terms of knowing what to do with it a little bit more and being able to change actual therapy decisions with results from ctDNA. One of the things I think about as a provider is that, every piece of data we get about a tumor or about someone's cancer is invaluable. Maybe we're not smart enough to know how yet. But when we assign somebody a risk, or we talk about someone being high risk or low risk, a lot of times things that go into that decision are things like someone's age or their tumor size. But those things are really just a proxy for what the genetics of their tumor are and what is going on inside those tumor cells. And so that's where my focus is in terms of trying to incorporate some of those ideas into earlier phase trials so that we can, really personalize the medications people get, because although osteosarcoma, is very similar from patient to patient, it's different from patient to patient. There are subtle differences, and I think paying attention to those and being very focused on those is going to help us in the future, treat patients exactly how that one patient needs to be treated.
I know that you allowed for people to be pre-treated with the cyto combination. Were any of the patients pre-treated with that combo on the study?
No, they weren't. That's a great question. Yeah, so we did allow that, but the prior regimens had not included that. So it's not a part of general upfront treatment. And you can see here that we had a number of patients, 6 of our 12, that had just received one prior regimen, which was kind of the standard dose or the standard approach for either Ewing's or osteo. But the relapse patients that we encountered had not received this combination, which was also, I think, encouraging as we were enrolling these patients. I think, I absolutely would have enrolled someone that would have had that previously, but I was excited to be able to give someone 3 novel agents to their body rather than just one.
Yeah. And so I know it's a little difficult probably because for Ewing's and osteo, I'm guessing that the primary and potentially even the second, third line chemo regimens might be slightly different. And I believe the Recur study was just it was Ewing's only, right? Was looking at Ewing's.
That's correct. Yep.
Only. And so in osteo, IFOS, I think you had IFOS on that list of 4.
I did.
Etoposide or IFOS as a standalone is a pretty common
Yes.
salvage chemo, as well as gemcitabine or gemcitabine with docetaxel. And I know you had mentioned like renal impairment being an issue, and I'm just curious if anyone's looking at, I know Cabo's, obviously being studied with MAP, which is fantastic in the COG trial, IFOS with Cabo or gemcitabine with Cabo, and
Yeah.
the renal impairment issue is a factor with those
Yeah,
two.
so that's a great question. So this slide had alluded to the fact that there was 4 regimens being investigated for this population of relapsed Ewing's. As I said, the bottom 2 were eliminated in the first look of it. They actually did complete this trial, and they announced ifosfamide as the winner, which was, I think, surprising to a lot of clinicians. But however, given the fact that there wasn't, I'd say, a large difference between ifos and toposi, providers are still hesitant uh, to not give toposi. So I think providers still use both of these regimens. And in terms of a combination of ifos and cabo, we certainly, we thought, is that a direction we should go? But given the fact that we think we would experience significant side effects in terms of both of these medications having renal issues, we have not gotten that idea past enough safety parameters to really move forward with it.
Are there any medications that would kind of help combat the renal effects? Because I know like when I got doxorubicin, there was something I was given for the heart effects. So I don't
Yeah.
know if there's anything similar to that.
Yeah, that's a great question. Probably dexrazoxane, the other long D word. So that's a great medication that we can give to kind of protect against doxorubicin issues. There are some medications we can give to protect against some cyclophosphamide-induced issues. In terms of ifos or cabozantinib, we have not been smart enough yet to find any supportive agents that are going to help with the renal issues. So that's another way to think about, well, how do we get better and how do we get better? There's not just new medications, but medications to help with side effects so we can give more of these other medications. So that's certainly, I'm sure someone, I don't know who it is, but I am not looking at that exact problem, but that's a great question.
Gotcha.
I might toss you a tough one just to get your thoughts on this, which I don't think were necessarily like answered or just in the study, but if you spin the wheel again, and there was that great slide you had about the different TKIs and the different targets. Yeah, that one. So some of these TKIs are commonly used, I think pretty commonly used
Yeah.
in osteosarcoma. And I think, and chosen because they are kind of, pan or multiple TKIs where they're targeting kind of different things.
Mhm.
And so, but having a hard time like choosing which one, right? Because we still don't have, there hasn't been like any definitive study about kind of which patients respond to different ones. And
Yep.
so I think often chosen based on just how tolerable they might be in terms
Mhm.
of side effects. But any kind of insights on that? I mean, this is actually really nice. I like how you've kind of illustrated this about, well, they're MTKIs, they're like specific
Yeah.
kind of targets or
The M stands
pathways.
for multi, so there's multiple things that their side effects include or that they're targeting. So yeah, that's a great question. Kind of how do we choose what's next or what do we do next with this? And I think the answer to that is probably what we call like second or third generation TKIs. So um, TKIs are in they're newish in respect to how long other medications have been around. So just we have the first antibiotic was discovered, in the I don't know 1920s or 30s or something like that, and we've gotten multiple generations of antibiotics now as we always discover new ones or get better or get better at either increasing our potency at the target or decreasing our potency at offsite targets. So I think that's the next step is not choosing a different one of the ones you're seeing here, but altering something like a cabozantinib to have less side effects at the kidney or less side effects at places that we don't want, or increased side effects or increased effect at the tumor. So I think that is likely what will happen in the future. It won't be one of these 8 that is the breakthrough, but it'll be a cousin or a nephew per se, a next generation of these that will be a little bit better, and then we'll just always be trying to make things better and better until we've cured everyone. And that's what we're going to do is just always work to make it slightly better as we can.
Oh, Walker, do you have another question before we?
Yeah, I guess if we're just like throwing out crazy things, uh, so could you maybe combine multiple TKIs and just lower the dosage of each, and then would that maybe present something that like throws the cancer off per se?
Yeah, that's been attempted, a multi TKI trial. I don't know I think there's been a few early phase trials for osteo and Ewing's. I know that it's been done quite extensively in adults. So there is definitely precedent and reason to think about combining more than one of these. The I'd say the hesitation would be that our only really good evidence of really good tumor killing and growth, like the kind of the really hard hammer that hits, is the cytotoxic therapy. It's the other ones. These ones are a little bit more, I'd say, subtle in their actions. They're incredibly important, and they're going to be needed to be used in the future. But to really, in my experience, to really hammer the cancer, you kind of need those heavy IV chemotherapies, and these ones are kind of the ones that are going to come in and pick off the last remaining cells or do a good job at the cells that are harder to get. But unless you kind of really hit it hard, maybe these TKIs won't be able to take care of the entirety of the tumor. They're just going to be important for kind of the harder to reach places and the harder to kill cells.
Where, yeah, that makes sense.
All right. Well, thank you so much, Dr. Campbell, for joining us on Osteobites today and for making it better for pediatric sarcoma patients. And I especially just appreciate your really trying to make these trials available to patients everywhere, because you're right, like it's quality of life is a big issue for these patients. So really appreciate your focus on that. More information on this and all Osteobites can be found on the MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And next Thursday on April 18th, we will be dropping a new episode of our AYA podcast, Osteo, where Osteo warriors Camille and Mia spill the tea on living with cancer as AYA. They're going to be discussing travel tips for osteo warriors and things to consider when traveling after limb salvage surgery or amputation, or also while on treatment. So you can find the episode on our website, on the MIB Agents YouTube channel, and also on your favorite podcast place. And we're going to be back with Osteobites in a couple of weeks on April 25th. We're going to be joined by Dr. Kristen Van Heist. She's a pediatric oncologist at Rambo Baby Children's, and she will be discussing TGF-beta inhibition as a novel therapy in osteosarcoma. And she's just opened a new trial, a Vactor-Sertib clinical trial for recurrent, refractory, or progressive osteosarcoma. So she'll be talking about that. You can find our Osteobites lineup for the next few months on our website. And if you have any ideas for future topics that you'd like to hear about, please feel free to email us at events@mibagents.org. Thanks again, Dr. Campbell and Walker, for spending an hour with us today, and to all of you for joining us. And we hope to see you back here in 2 weeks on April 25th when we chat with Dr. Van Heist about the newly opened Vactor-Sertib trial. Thanks, everyone. Thanks, Dr. Campbell. Thanks, Walker.